All right. I think we have a few people joining slowly, but I'm going to go ahead and go over some housekeeping items and introduce our speaker for today. For those of you who don't know, my name is Quincy Christian. I am the program coordinator for Parkinson's Association of the Carolinas. Just some quick housekeeping items. Everybody is muted on entry, just so we don't interrupt the presentation. You are more than welcome to unmute yourself to ask questions or communicate with each other. We would love for you to turn on your camera so we can see your beautiful faces. I do not care if you are eating or snacking. You'll probably see me snack a little bit throughout too, so turn your cameras on. We'd love to see your face. For those of you who are not familiar with Zoom, there is a chat box at the very bottom of your screen in the very center. If you don't feel comfortable unmuting yourself, you are more than welcome to ask questions or communicate with us in the chat box. We will continue these virtual support groups on the first Wednesday of every month at 2 p.m. I believe next month we have Dr. Mark Hirsch coming on to speak, and you'll be getting updates about that regularly, and we'll send out another update the day of. So without further ado, I'm going to introduce Jared Skinner. He is from the Department of Health and Exercise Science at App State. And today he's going to talk to us about how exercise impacts non-motor symptoms of Parkinson's. I'm going to go ahead and turn it over to you.
Awesome. I have to make sure I unmute myself. I've given half a lecture before and no one actually told me I'm still on mute. So yes, thank you for having me today, and thank you all for coming and giving me a little bit of your afternoon to talk a little bit about what I'm pretty passionate about and what I enjoy. So I'm going to, this is a support group and I want to talk to everyone. And so part of my talk is about asking questions, and please feel free to, utilize the chat function or just ask the question to me. I'll give you opportunities to do that throughout the presentation, and just to make sure everyone's following along. So I'm not gonna, hopefully I won't lecture or bore you to death. So it should be pretty fun. So I'm gonna go ahead and share my screen. All right, can everyone give me a thumbs up if you see a black screen with my name on it? Awesome, thank you everyone. All right, so let's go ahead and get started. So I am a professor here at Appalachian State University. I did my undergrad here and my master's, and then I went on to the University of Florida. When I was there at the University of Florida, I kind of fell in love with clinical biomechanics. And in doing so, I was partnered with a really, really good mentor named Dr. Chris Haas, who's one of the leading experts in Parkinson's, especially biomechanics of Parkinson's, specifically looking at how individuals walk and stuff like that. From that point, I was partnered with the Center for Movement Disorders and Neurorestoration down in Gainesville, Florida. I don't know if any of you ever heard of that. It's a very large clinic, probably one of the largest in the Southeast. Dr. Michael Oken who was the head of the Parkinson's Foundation and the Michael J. Fox Foundation for a while, was one of my mentors there, and I really learned a lot from them. But that got me asking a lot of questions. And so one of the things we're going to get in today is kind of what my area of interest are, how I kind of got started, and then ultimately how I can help the Parkinson's community up here in the high country, but also across the state and the surrounding area. So kind of get into that a little bit today. And so I first kind of got involved in Parkinson's because I had a training in biomechanics, specifically looking at geriatric populations and how they would change over their lifetime. So we know that as we age, we tend to see a decrease in muscular performance. But if you start working out and you start going to rehab, we can actually change that a little bit. We can reverse those effects to some degree. But with the introduction of Parkinson's, or just getting older in general, we start to see a decline in that neural input to the rest of the body. And so in that point, we can't really train the same way that we normally have when we have some sort of deficit or injury. So in this case, it can actually influence our ability to do a lot of different activities, just simple things. Now, again, these are primarily the motor symptoms, but again, there is a connection between the motor symptoms and non-motor symptoms. And we'll get into that in just a little bit. But understanding this idea, we have to start thinking about training and rehabilitation a little bit differently. And so by doing this, we have to start thinking about training the brain. And can we do that through this idea of neurorehabilitation? But it's important to note that when we try to do this neurorehab, a lot of people look at it from just one little facet or one perspective. What we're trying to do here at Appalachian State University is make that a little bit more broad. And we do that through this, the IHHS, which is the Institute for Health and Human Services. So this is the Blue Cross Blue Shield North Carolina Institute of Health and Human Services. This is in Leon Levine Hall. So if any of you that have ever been to Boone, it's going to be at that brand new building next to the hospital. And this is embedded in the first floor. Now, this is a really, really nice clinic. This clinic sees primarily speech, speech, language, and hearing impairments. You do have to be referred to come to the clinic for a clinical appointment. However, I've introduced this aspect of a comprehensive geriatric assessment on the basis that we reach out to every individual. We don't discriminate, in any terms as far as collecting and providing this opportunity to individuals. And so we're including individuals with all forms of movement disorders, cardiovascular disorders, so on and so on. But this comprehensive geriatric assessment is this multidimensional, interdisciplinary kind of diagnostic tool that allows us to look at medical, psychological, and functional capabilities of a number of different populations. So the reason this is such a cool idea is because it allows us to coordinate with multiple different disciplines and integrate those into a plan that can help manage the symptoms of Parkinson's disease. And even further, we can probably prevent or delay their complications or worsen the severity over time. So understanding the person as a whole is really critical for implementing a really effective treatment. And we do this through 4 different assessments. And if you look over in this side of the graph, we see the patient-centered outcomes. Now, with the patient-centered outcomes are going to be specific to the Parkinson's group. So in this case, we're looking at gait and balance function, which is what I'm primarily interested in, the psychological aspect, as well as the clinical aspect. So those are the 3 domains in which we're going to try to collect a number of different data points. And we do this as far as the gait and balance collection. We also do repetitive speech and speech language outcomes. We do cognitive outcomes, and then we also do a dietary plan. And through this dietary plan, we're able to assess individuals' needs for a proper diet in the surrounding community and make sure they have access to that. And there's no limitations that would hinder them access to appropriate food sources. And so that's kind of what we're looking at through the patient-centered outcomes. But the other really interesting part that we're looking at are the student-centered outcomes. So we are having students, graduate students and undergrad students participate and kind of work with the Parkinson's community. We do this because not a lot of young people are really familiar with Parkinson's, or, to be honest, just older adults. There tends to be a kind of an intergenerational divide. And what we're trying to do is influence that a little bit, to have a little bit more of a positive influence. And so people can see that in a better light. And so they're not really anxious about, getting older. And it's something that everyone should look forward to instead of, not looking forward to. And so I'm going to just spend a little bit of time just kind of talking about these services, just because I want to let everyone know what we can do here at App to help everyone. And then we're going to kind of get into that, the research aspect of it. And so the main thing that I try to look at is the gait and balance. Now, we all know gait disturbances in Parkinson's can be bad. Obviously, it's worse in some cases than it is in others. And so it can progress. It can cause a lot of issues, whether with, discoordination, slowness of movement, et cetera, et cetera. And a lot of times they require a lot of input. And so what we're trying to do in this case is see where those deficits are going to lie. And so one of the things that we have here at App State is the Gait and Balance Clinic. And so one of the things that we are able to do is to do a full spectrum of analysis looking at individuals' motor functions. So primarily looking at their dynamic balance capabilities, as well as their gait capabilities. And gait's just walking. So one of the cool things that we do within this assessment is we're able to collect that while you're waiting as you check into the clinic. So one of the cool things, I've got a short little video for everyone to watch that basically just shows, this is from one of my graduate students. I got their permission to show everyone this, so I'm not violating any HIPAA rules. But this is some of the neat information that we get from here. So when we come here, and I apologize, I had to record this on my phone. But you can see here, all we basically have the individuals do is walk at a normal self-selected pace up and down this walk mat. And this walk mat is instrumented with thousands of little force sensors that allow us to detect where they are in a certain space. The other aspect of this is it allows us to determine the individual's balance. So if we come over here in this test, we can track the individual's sway area and how much they move when they're standing still. Now, looking at certain measures, whether it be stride time, step length, or sway area and balance, these are all going to help us predict individuals' gait and balance outcomes. Are they going to be at risk of falling? Are they outside of the normative data? Is there some sort of issue that we should be aware of or try to follow or track so that we can properly intervene with these individuals? So one of the beautiful things about this program is that it allows us to not only take an appropriate snapshot of your functionality at this point, but we can also track this over time, which makes this a very valuable tool. So if something changes in your diagnosis or how you're feeling, or if there's changes in medications, activity level, whatnot, we can see using these very, very sensitive measures. Now, I'm sure you've probably had clinical assessments of gait and balance before, but the stuff that we can do here is a much more sensitive tool. It can detect minute changes and allow us to appropriately intervene at a kind of quicker time point, something that you may not get on a timed up and go test or a 6-minute walk test. This is going to be a little bit more sensitive and allow for appropriate tracking of functional capabilities. So the next aspect of the clinic service is we try to go through speech and language therapy. Now, this is Dr. Sarah Young, who is a clinical speech pathologist here at App State. She sees most of the Parkinson'S, stroke, and most movement disorder patients that come in for speech and language therapy. She's actually working with me on another project, and we're going to get into that in just a little bit. But some of the speech therapies that we do here is control of speech rate, stress, expression of motion, breathing. We also have the LSVT Loud program, the Speak Loud program here. And so we do a full array of tests. For those of you that are familiar, we do a CAPE V test in which you kind of make sounds and read a couple sentences. We also, some of you who may have done some of this, the speech and language therapy before, done the grandfather or the rainbow passage. And so we record that to track your speech level. And so at each visit, we're going to do these tests. And the beautiful thing about these tests, we can do all the tests in about 30 minutes. So most people do them just after their visit. If they come here for a clinical visit, we just ask them, they sign off, and we do this comprehensive geriatric assessment. The other aspect that we look at is cognitive capability. Primarily, we're trying to look at executive function, which is kind of that motor planning and that strategy aspect. And so we do this by the measurement via the MoCA test, which I'm sure you've all heard of the MoCA test before. This test is commonly used. We also have used the mini mental state examination. All of them just allow us to look at different domains of cognitive function. And it's just another one of those key parts in this comprehensive geriatric assessment. And then the last thing that we look at is the nutritional profile. So we ask individuals food diaries, we give them nutritional education, food psychology, how they should, how do they feel about food, as far as their dietary strengths. We try to provide opportunities and give them a lot of information out there. And so the clinic and I have kind of partnered together, not only to work at kind of geriatric populations, but also primarily looking at a lot of Parkinson's populations. And so the beautiful thing about this is we do get a wide range that you can take back. All this information is free. All of these tests are free. And that's one of the beautiful things about this, that we provide this opportunity for you to collect the information. We give the power back to the patients. And so then they can take the information to their primary caregiver or their neurologist or their therapist and have them review it with them. In the fall, we're going to have social work actually be intertwined within here. So allow for them to kind of communicate with you and kind of follow up with you as well. So this is one of the neat kind of things that I and the university provides, and is something that's available to everyone. So if you're up here visiting and you want to give it a shot, you can reach us through the website, and I'll provide my contact information at the end. But I know this was kind of a plug for what we do, but I thought it was pretty important to let everyone know. So does anyone have any questions for me about what we're collecting, what we're doing here?
Jared, for the nutrition, I guess, resources, is it general nutrition, or is it even a little bit along the lines of medical nutrition therapy? I'm just thinking I'm a caregiver for someone who is having some, I guess, competing medical issues that have different dietary needs. So we're really struggling with how to manage all of those at the same time.
Yeah, that's one of the beautiful things here. We have a great nutrition program that's working not only with, they're all, a lot of the registered dietitians and nutritionists, really smart, but they are in the medical field. And so they can provide medically driven dietary needs and information to you. So yeah, they, the people that I have worked with personally love to answer questions. And so if you don't mind, you can email me after this and I can provide you with some of that information and someone to reach out to. Good deal. Are there any other questions? Priscilla, are you trying to, yeah, I think you're muted.
There we go. I was thinking, how do you get involved in the gait and balance? Like, how would, if my husband has Parkinson's, if I wanted him to be evaluated with that, how would I go about getting that done? I live in the Raleigh area.
Yeah, I mean, the easiest thing from my aspect, everything we do is free and everything we do is accessible. So if you did ever want to make a trip up to Boone, all you would have to do is email me. The clinics runs basically Monday through Friday from 9 to 4. So if you wanted to come up and do that, we'd be happy to do it for you. Every individual is welcome for this program. This provides a scholarly need for our students, but also provides a big need for the Parkinson's community as well.
Okay. So would you need to have well, if you give me, I will receive your email. I mean, get your email address. And so then we could schedule something to come up to do that?
Yes, ma'am. All you would have to do is just, like I said, it's usually going to be here. We do like to have it scheduled. Yep, but just shoot an email to the interprofessional clinic or myself, and we'll get you on that schedule for basically whenever you need.
Okay, that's great. Thank you.
Yeah, and the beautiful thing about it is you're not going to spend a whole day up here. I mean, it's really nice, but it's about a 30-minute assessment
Okay.
to go through everything. So it's
Wow.
good, and you'll have access to all the information. We do a little report for everyone, and we give it to those people, so then they can go back and review it or share it with their medical professionals.
Okay. All right. Thank you so much.
Jared, I had a question.
Yes.
I've had a thorough neuropsych evaluation, and one of the things that they pointed was I have a split attention or divided attention problem. Are you going to speak to that anywhere in this presentation, or can you?
With this presentation, I was going to go a little bit more, a little bit different route rather than cognition. I do know we are working with psychology right now, and actually speech and communication disorders. And we're actually going to be talking a little bit more about that later on in some of the research that we're doing in the future. I can, if you want to email me afterwards, we can speak on we can set up another one. But for this meeting, it was going to be primarily kind of talking about some of the sleep disorders and autonomic function and some of the other non-motor symptoms.
Okay, thanks very much.
Sorry about that.
No.
Awesome, great questions. And again, if you have any more, I'd be happy to answer those later on. I don't think there's anything in the chat. Haven't seen anything. Okay, so if there's no other questions, we'll go ahead and move on a little bit. So like I said, I was classically trained as a biomechanist. And so I primarily focused on more of the motor symptoms of Parkinson's disease. And some of my past research focused on, the functional capabilities of what we saw. And so these are just some of the ones that I've highlighted that have looked at the functional outcomes that we've talked about. So, individual, how can force variability? So the amount of force or control that you have in your ankle muscle, how does that contribute to your ability to walk? Well, we found a lot of really cool stuff, and we showed that higher amounts of variability were reflected in higher amounts of gait variability. And if you're not aware of higher amounts of gait variability, so that means the step to step or stride to stride differences. So if your stride length for one stride is different than the next, so the variability within that has an increased risk of falls. It has been shown to predict individuals who have fallen if they're going to fall again. So just some kind of correlations that we've seen there, but a lot of it comes back to just looking at overall strength and the muscular capabilities. We also found a slowness of movement. So we see the bradykinesia not only in the upper extremity, but also in the lower extremity with stepping task. And we see a little bit of variation within that. And a lot of that had to do with the way the muscles distribute and kind of produce force. And one of the key characteristics of what we found in these studies is that individuals with Parkinson's are able to do the same things that people without Parkinson's are. Basically, from the naked eye, they may look exactly the same. But if you go through and look at it a little bit differently, what we see is that individuals kind of change their motor plan in order to accomplish that task. So they reorganize their system in order to do this. And we saw this as a kind of a redistribution of the force output from the hips and your calf muscles. And we saw that Parkinson's people actually switched those around in order to do the task. We saw no differences within the task, but the way they performed that, they were different and could kind of reorganize or redistribute those joint torques in order to do it. So that got me started thinking about where the connection lies. So we see all these motor functions, but every time I would talk to the individuals with Parkinson's, they would tell me that these, in their case, weren't the worst symptoms. And so they started talking to me more and more about the non-motor symptoms of Parkinson's. And there's a million of those, and they all vary, but we started kind of thinking about those as I came to App State. And so one of the things that I wanted to look at are, what are some of those non-motor symptoms? What are the worst ones that these individuals would complain about? And so one of the biggest things that they talked about was sleep. And with sleep, we wanted to know a lot of different things about sleep. I can tell you, I'll be the first one to tell you, if you don't have sleep, you're not going to ultimately feel good. You're going to see a decrease in a lot of different performance aspects, cognition. You'll see quality of life tend to go down chronically, so on and so on. So one of the things that I was interested in is understanding how exercise and physical activity can influence individuals' motor function, but now I want to look at how can it influence those non-motor symptoms. And so one of the things I started looking at is physical activity and exercise. How can that improve sleep profiles? And so I partnered with a professor here, Dr. Scott Collier, who is a mentor of mine, who was a great collaborator. And we performed this study, and we'll go over what that study is in just a little bit. But that allowed us to basically look at the problems we see in sleep and then further explore some of those other issues. In this case, we're looking at autonomic function. And so with autonomic function, we see increases in sympathetic and parasympathetic activity, which is basically related to your nervous system. And you probably all heard of the fight or flight response. So when you're excited, you see an increase in sympathetic activity. And so your heart rate goes up, respiration goes up, you start to sweat a little bit. And so in most cases, most people respond appropriately to that. But what we've actually seen is there's some complications in those with Parkinson's that influence autonomic function. And basically, we see increased and decreased activity where we shouldn't. And so one of the things I wanted to look at is, well, that's obviously not a very good thing. So how do we improve that? And one of the ways I did that is asking the question is, can exercise improve those non-motor symptoms? Now, in healthy populations and stroke populations and a number, even in Parkinson's, they've done a lot of research on how exercise is very, very beneficial for the management of different symptoms. Most of them have to do with the motor symptoms, but a handful of them do focus on the non-motor symptoms. But again, a lot of these are more subjective and kind of questionnaires. We wanted to kind of get away from that and kind of look at some objective measurements. So then we started looking at, well, what type of exercise? And so we had to think about it a little bit more. And Dr. Scott Collier has already done some research with resistance training, and it has positive effects. I've done in the past how it has a lot of positive effects with increasing muscle mass and increasing bone mineral density. And will actually improve a lot of other symptoms kind of related to just general aging, but also improve a lot of those specific to Parkinson's. And so then I wanted to ask the question of, are the motor symptoms and the non-motor symptoms related? And so one of the things that I started looking at, like we talked earlier, was, can speech be related to a motor function? Is non-motor function, or these non-motor issues, related to the different motor function issues, specifically talking about freezing of gait? Now, again, most of this usually comes with individuals who are a little bit, it's progressed a little bit further, but it is something that we need to look at. And then can we improve one if we improve one, can we have a positive effect on another one? And so we've looked at this a number of times. And so basically what we did, we came up with a study to ask or to answer some of those questions. And so we wanted to look at how exercise impacts non-motor symptoms of Parkinson's disease. And so with this, we did a quick little pilot study, and the individuals here in the high country were excellent to work with. They're just the nicest people in the world, and very eager to get back to research. Now that some of the COVID restrictions have released, they are calling, ready to get back to work. But we have basically, we did the study. We enrolled 11 individuals with Parkinson's and then 12 age-matched controls. And we looked at a lot of different things, kind of going back to that comprehensive assessment. It's just not one variable. It's a lot of different variables. So these are some of the variables that we looked at. So we wanted to look at their physical activity level. We wanted to look at their cognition. We wanted to look at their non-motor symptoms, and we did this through their the 2 questionnaires, the PDQ-39, as well as a non-motor symptom questionnaire. And then we looked at freezing of gait. So we just wanted to see kind of a broad spectrum of how these individuals were performing, both in the non-motor sense as well as a kind of a motor sense. And then we kind of dove into it a little bit more specifically and tried to answer some of those questions that dealt with sleep and autonomic function. So we did a cardiovascular autonomic evaluation. We did sleep data on these individuals. We also did ambulatory and nocturnal blood pressure. And then we evaluated their quality of self-reported quality of life. And so we set up this design over 3 days. So on the first day and second, it was the 3-day design. And as you can see right here, they were consecutive days. So individuals came in and we did a number of different tasks. So on the first day, we tried to go through the full gambit and we did all of this information. So the physical activity, cognition, we collected all of that. So you can see here, we did the autonomic test. We also did a strength test to allow us to determine what type of intensity we were going to put them at during the intervention on day 2. And then we introduced them to our sleep profiler. Now, some of you have probably done some sort of sleep test before. I've done a sleep test before. And I will be the first one to say I do not like doing sleep tests because I like sleeping in my bed, and going into a sleep study chamber, hooked up, being evaluated, I never get a good night's sleep. And so that's one of the downsides to a lot of sleep control. And I'm going to tell you how we kind of were able to work around that. So on the second day, those individuals came in and we performed an exercise test, or exercise intervention. Over 6 exercises, they did 3 sets of 10. And this was based off of 60% of their 10 repetition max. So they came in, everything was pretty easy. It was challenging, but not to the point to where it completely exhausted them or they had a lot of fatigue or anything. So we measured fatigue pre and post, as well as the next day. And there was no signs of fatigue within there. They were a little tired, but nothing crazy. And then the following day, we had the individuals come in with and redo the autonomic testing, as well as the last day of the sleep data profiler. And so the cool thing about this, individuals were able to take all of the information or take the sleep profiler home. So they didn't have to come into the lab. So the only times they came into the lab were those 3 days and to do some of the testing. Now, when they went home, we were able to get a lot of information. So as far as the collection of sleep data, we utilized a product device known as a sleep profiler. This thing is amazing. It works very, very good. Basically, it just has 3 little electrodes and you just put it on like a headband. I've used them. All of our patients have used them. As long as you don't put it on too tight, it's generally not an issue. And the beautiful thing about that is, Luli, the only thing you have to do is right before you go to bed, put it on, click the little button at the top, it'll beep, and then you go to sleep. And then when you wake up, you turn it off and then plug it in. And we have those individuals do that for 3 days, consecutive days. And the beautiful thing about this, there's so much information we were able to extract from it. So we were able to get ECG readings, pulse rates. We were able to look at different head movements. As you can see here, these are all the different variables that we could look at. So we could look at REM sleep, so that rapid eye movement, the non-REM sleep. It allowed us to collect a lot of information. And Dr. Scott Collier has done this a number of times. And so this actual device has been validated in the research community and provides a lot of really good information. And so I'm just not going to bore you because I could talk about this all day, but one of the really cool things that we saw is and it kind of goes to with what else we're talking about, is we looked at something called autonomic activations. Now, that's basically just when your pulse rate increases more than 20%. Now, you think about during the sleep, your nervous system basically starts to get reduced. and most of your body starts to kind of slow down. So within about like 5 minutes, when you start to drift off to sleep, your heart rate's going to gradually slow down to its resting rate. And that's basically going to be known as kind of this light sleep area. You also see your body temperature starts to drop, your muscles start to relax. And people spend about half their sleep, their night sleep in this kind of light sleep phase. And then during the next phase, kind of a deeper sleep, you're going to see an even further drop in blood pressure. You're going to see a further drop in heart rate. And you just going to start to get a different change in which nervous system is going to be active. And so one of the things we looked at is this autonomic activations. And basically what we're seeing here is an increase in that sympathetic activity. Remember I said earlier, that's that fight or flight response. So you don't want a rise in heart rate because then you start to move and your quality of sleep and the sleep efficiency tends to go down. And one of the things I didn't report on, but we found that individuals with Parkinson's on the three nights, their sleep efficiency was much worse than that of the controls. But what we did find is after the first night of exercise, individuals did improve their sleep efficiency up to 20%. Now it was close to the same as the controls. And the cool thing about it, they were able to sustain that over the next night as well. So some positive effects so far. But then one of the other things we looked at was this autonomic activation. And so after 1 day of exercise, these are two graphs I want to put in here. And one of the things I want to just kind of show, so this is day 1, this is day 2, and this is day 3. These are the controls. And this is day 1, day 2, and day 3 in the Parkinson's group. And one of the cool things, so after one bout of exercise, so on day 2, they did their exercise. When they went home and slept, look what happened. The amount of autonomic activations decreased significantly. So this would be reported. So this is some of the data that we're going to be reporting on shortly, that after one bout of resistance training, we can see improvements in autonomic activity. The other really cool thing about that, if you look at day 2 and day 3, there was basically no change. So that shows us that the changes that resistance training can do, the body, individuals with Parkinson's are able to retain that over a period of time. Now, again, we just looked for 3 days, so I can't speculate if this would change, after 4 or 5 nights or a week. But this is some pretty good evidence in what we've seen here. With the control group, we didn't see any changes. Their autonomic activations were pretty steady. But with the Parkinson group, exercise did have a very nice effect. And so if we're able to reduce the amount of pulse rate increases, basically we see a reduction in that sympathetic activity. And ultimately, we should be able to improve sleep quality. The next thing I want to kind of get into that we looked at as far as the sleep, we did ambulatory blood pressure and nocturnal blood pressure. So during sleep, basically, or this non-REM sleep, we see an increase in that parasympathetic activity. And again, that parasympathetic activity kind of calms you down. And that's what we're looking for. But unfortunately, we tend to see a reduction in the cardiac sympathetic activity. Well, when we see that decrease, what happens is we kind of get this dipping effect. And this dipping effect is pretty normal. Dipping is actually, usually we see this as about a 10% drop in that mean arterial pressure compared to like when you wake. And so we can see that right up here in the controls. Okay, we see that normal drop in blood pressure as they're sleeping. Now, blood pressure dipping has been shown to actually been kind of a healthy cardiovascular response. And so dipping is good. In the Parkinson's population that we looked at, unfortunately, what we saw is that we saw non-dipping. So we saw this kind of increased in blood pressure in this case. And this is the top graph is systolic or the top portion is systolic and the bottom portion is diastolic. And you can see that on both aspects. Now, again, we just recorded it at night. So this value that you see in the white on both sides, okay, that's just going to be more of a kind of an average for the population. So we didn't actually collect that, but what we did see is based on the average, we do see this drop in the control group. And unfortunately, we see an increase, in this case, in the individuals with Parkinson's disease. So we want the blood pressure to drop. We want the blood pressure to get back down. We won't put less stress on the cardiovascular system. Now, we started asking, well, why do we see this? Well, a lot of this is controlled by that cardiovascular autonomic system. And so when we have that control, then we need to see, well, what's going on with this autonomic system? Why is it doing this? And so what we saw, unfortunately, that there was no real decrease in blood pressure or this non-dipping effect after exercise. So that led us to believe, well, maybe resistance training is good, but it really doesn't have a profound effect on this nocturnal blood pressure. And so if we don't have that, that leads us to believe maybe there's another type of exercise that would be a little bit more beneficial. And we're going to talk about that in just a little bit. So then we started thinking, well, let's start talking about this cardiovascular autonomic data. So with the cardiovascular autonomic data, what we had individuals do is hook up to basically, I'm sure some of you have done an EKG or ECG before, where you sit there with the little electrodes on your chest, and we basically just recorded heart rate function. And we had them do that standing and sitting a series of times. Now, one of the things that we looked at was there's one of the ways that we examined autonomic function is something called heart rate variability. Now, heart rate variability can be measured in multiple different ways. And like I said, I'm not going to go too much in detail, but you can either do it in a time domain. So if you look at like a EKG plot, if you look at from the R to the R, so the big interval between there, you can look at that. Or in this case, you can filter out the two frequencies that the electrical frequencies that are coming through there. And we can look at a low frequency and we can look at a high frequency. And what we saw when we looked at the low frequency, that there was no differences in the controls, but in the Parkinson's that there were. So this is measured in pre and post. I'm sorry, they're a little backwards. Pre should be before, so it may be a little confusing, but we look here, the Parkinson's, it's elevated in this case. Well, after exercise and getting acclimated to everything, we see a reduction in that LF. Now, LF, which is low frequency, is predominantly determined by that cardiac sympathetic modulation, which is a good thing. We want to see a reduction in that. Because again, if we see a reduction in that sympathetic activity, we're not going to see those big spikes in the autonomic activation that we see in the sleep. And so we're able to improve those. So we want to decrease that sympathetic drive. And we see here after 3 days, we were able to do that. Now, one of the other interesting things there, we can see this change right here, which is nice. That's clearly an improvement. Through statistical analysis, I found that was a significant improvement. Now, the interesting thing here is that it also had an effect on something called the LF to HF ratio, which is low frequency to high frequency. Basically, it's a really good way and a really effective way of looking at the autonomic nervous system. So how it directly impacts your heart's activity. And this is a really good way of looking at it. And so we looked at it, and surprisingly, you can see this is the LF-HS ratio. It looks very similar to the LF. So it actually changed to the same degree. So we see an increase in HF, the high frequency, which I didn't report on because it wasn't significant, but it was a movement. But that change in both the LF and the HF ratios lined up to what we see right here. And what we see is an identical comparison within here. So we drop that LF ratio. Now, again, we don't see a drop. That LF-HF ratio for the controls was completely the same. I didn't report on that but it was the same. So we see a significant difference in here. So far we've looked at and we found that, well, resistance exercise can improve your sleep quality, and it can have an impact on your cardiovascular autonomic system, which is a pretty good thing. Because again, if we can decrease the activity, you're going to sleep a little bit better. But we weren't really convinced that it was going to really have an effect on that ambulatory blood pressure, because we want to get that blood pressure to drop. We want to see that dipping. But in this case, we really didn't see it. So that led us to answer a couple more questions. And so the next step in this process is we want to look at the effect of a multimodal exercise program. So we want to combine resistance training and aerobic training to see if that has any improvements on sleep and autonomic dysfunction. And so obviously I just don't want to do the study again in the same manner. There's been a lot of evidence that shows that, more than one time is probably going to be more beneficial than going one time. No one just goes to the gym once and says, okay, I'm done. I don't need to go to the gym anymore. Well, if you do, you need to go more than that. So one of the cool things here is we're able to expand on this. And what we're going to do is we're going to do a 4-week intervention, having individuals come twice a week. We did this because has been shown to show actual improvements in geriatric populations. So it is validated in that sense, but it also allows us to make it a little bit more feasible. So if it's feasible here, then it could be feasible and it could translate to the normal population. So if we find really good results, then you could utilize these results as with a minimum of 2 days a week, improving some of these outcomes. Now, we haven't done the study yet, but that's the process and where we're going. Hopefully it will improve. So we're going to do a 4-week intervention. So will these extended intervention lead to further improvement? So we're going to see greater improvements in areas we didn't see, or are we going to see improvements that last a little bit longer? We noticed we measured it 1 day afterwards and we still saw improvements. Well, what about a week after? That's the next step in which we want to ask. Then we also looked at the type of exercise. Will different exercise influence the response? So cardiovascular exercise has been shown to improve a lot of those ambulatory blood pressure profiles in normal individuals. So maybe by adding that on, we can improve what we see in the Parkinson's group. And then ultimately, this leads us to a lot more questions. And so, our ultimate goal here is to reduce those non-motor symptoms, whether they be kind of gastrointestinal, urinary, cognitive, or whatever. We want to improve those symptoms. And so it leads us to a lot of different questions within here. Now, the other area that we're going to get into is that freezing of gait thing I talked about earlier on. But before I get into that, does anyone have any questions on what we've talked about so far? I know it was a kind of a lot of information, so I want to make sure you can unpack that and see if you got the overall picture of what we saw. And gives me time to get some water. All right, well, I'm gonna come back later and I'm gonna ask you again. So if you need a little bit of time to think about it, go ahead and do that. So the next step in our process of, we want to look at, how do motor symptoms and non-motor symptoms correlate? And so we started thinking about this a little bit more, and I started working with my colleagues over in communication and speech disorders. Some really, really awesome speech pathologists got me thinking. And so we came up with this plan to look at freezing of gait in repetitive speech disorders. So I'm sure you're all familiar with freezing of gait, that hesitation to stepping, that inability to take that step. And we've also seen this in repetitive speech disorders, not isolated to Parkinson's, but within the speech and language community. This repetitive speech disorders, this kind of hanging up on the words, mimics what we would see in freezing of gait. It's just one's you're trying to vocalize, the other one you're trying to take a step. But we do see the relationship, and there has been some reports looking at how they are related. Now, again, this is usually for more advanced stage Parkinson's that you're going to see both of these, but it is something that can show up throughout. And so I started to look at this a little bit more and try to get a better understanding of what we saw. So if there is a possible relationship, how do we improve that? And so we wanted to look at the link between the motor and the non-motor disturbances. And then once we find that link, one of the things that I want to do is use different types of interventions or neurorehabilitation to improve the patient outcome or reduce the symptoms of what we would see. Again, like I said earlier, if we improve one, are we going to see an improvement in the other? And if that's the case, are we going to see improvements elsewhere outside of the two domains that we are of particular interest? So the two modalities or the two therapies that I use to analyze this or to kind of answer some of these questions are TDCS, which is known as transcranial direct current stimulation. Now, some people may have heard of TMS. So TMS is transcranial magnetic stimulation. And that's actually been an FDA approved therapy for depression and other ailments. And so it's a pretty popular tool that people have used. The other tool that I've used is a non-physical intervention. So many of us know during COVID, we weren't allowed to go out. You couldn't go to your rehab specialist. You couldn't go to your therapist. You couldn't do the things you wanted to do. So we had to think outside the box. So I came up with, after some research, I found this idea of observational learning, which is basically your ability to kind of pick up different patterns just by watching it. And we're going to go over that in just a minute. So I just want to take a brief moment to talk about these two and what we've done with it so far. So TDCS is a non-invasive brain stimulation. So an invasive form of brain stimulation would be like the deep brain stimulators. We are not doing anything like that. As you can see here in these figures, basically we just put these sponges on the brain. Specifically, we can look at the motor cortex or the premotor cortex. Like I said earlier with the cognition levels, I'm really interested in the premotor, so that executive function, that planning, goal-oriented movements, that's what I'm specifically looking at. And so you can see that right here in this area. And this is a stimulator, and you can see me putting it on one of our grad students who graciously volunteered to do this. But this is a great way for students to kind of learn a little bit too. But the way this works is we send an excitatory and an inhibitory signal that basically changes this kind of the flow, the electric current through in the area that it's stimulating. And so in layman's terms, it basically makes it easier for you to learn. And we've found some data that after, having these individuals put the stimulator on and do different tasks, we saw that they were able to learn these different tasks much easier. And so we had individuals walk on an obstacle course. They did it with this. What we saw that after they got done, they improved their gait functionality. And then they came back a week later, and those that had the actual stimulation did a lot better. And so that was a pretty neat outcome. So I was like, well, does it have to be physical? Can we use those observational aspects? And so what we looked at is we tried to have those individuals do this. And so observational learning is a really cool technique that allows you to sit at home, watch a video, and get better. Sounds pretty good, right? Well, we've looked at this, and we think that we can facilitate greater changes if we combine observational learning as well as with or in conjunction with the non-invasive brain stimulation. So again, observational learning allows you to learn a new skill, but with the stimulator, we can do it much quicker and much faster and improve those functions. So my idea is to take these two modalities and apply it to freezing of gait. we can improve freezing of gait through these function, or if we apply it during a language speech therapy session, have those individuals perform the different vocal exercises to allow them to learn to speak a little bit easier with the TDCS, or are we going to have improvements? And so that's one of the things that we're looking at as well. We have some really good data with this. We've actually collected so we had individuals watch a movie, then performing this task. And what we looked at is the amount of brain activity. And what we saw compared to rest, we increased brain activity watching the video, and then we increased brain activity watching the video and then imagining yourself doing that. For anyone who's ever done like an MRI or anything like that, usually if you do like a certain task, they could do some mental imagery. And so they tell you to imagine you're walking, or imagine that you're walking, or you're riding a bicycle. And so it has shown that we see either greater improvements. And so this is without the TDCS stimulator. So if we can improve these responses, even without the TDC or even without the TDS stimulator, with it, we should be able to increase it even more. And so what we see big improvements within here. And so one of the things that we want to look at is, can we take this therapy, improve the speech issues that we see in Parkinson's disease? But also, can we get away from those physical therapies? Maybe we can do this observational where you're just sitting at home watching. Some people may be bedridden or have, recovering from injury. Hopefully we'll never go through another pandemic. So you'll be able to move again. So that's one of the things that we've looked at. And we've just kind of come up with multiple different ways to address some of the symptoms of Parkinson's. So that is, I didn't want to kind of go crazy into detail, but that's just some of the research that we're doing here at the University of Florida. Obviously, we've got some more stuff going on once the semester kicks back in, and I'm happy to share that with individuals. But I've taken up a lot of your time, and I really, really appreciate you allowing me to come on here. So I'm going to stop sharing my screen and now give everyone the opportunity to ask any questions that they may have, or maybe give me more ideas and more research I can do. So.
I know I saw a few people unmute themselves earlier in the presentation to ask a question, so feel free at this time. Your unmute button should be either you can just press spacebar, or it's going to be at the bottom left hand of your screen or beside your name if you're able to find it. If you're not able to unmute yourself, feel free to enter any questions or comments into the chat box at the bottom center of your screen.
Can you hear me?
Yes, I can.
Oh, okay, thank you. I would like to know if it's a good idea for an individual with Parkinson's to exercise late in the day. I was always led to believe that that isn't a particularly good thing. But since you're mentioning these effects of exercise on sleep, what is the accepted view of that?
So I can speak to what we see in normal, non-Parkinson's populations. And a lot of that goes or has to do with the intensity level. So a more intense or longer duration is typically going to have an increase in that sympathetic activity. So it's going to take a lot longer for you to kind of wind down. Now, if you're doing something that's submaximal, something that is, increasing your heart rate, but not to a degree that's, really, really challenging you. Once you start, 5, 6 o'clock at night, start doing stuff that's going to be a higher intensity, even resistance training, or even a hard run or anything like that, that's going to take a lot longer for you to kind of bring that activity back down to a normal level. So it may take a lot longer for you to go to sleep. And we actually saw that. So every patient or every participant we had come in all performed their stuff in the morning. So that's one of the future studies that we're going to look at, is look at the differences between, morning and afternoon time as far as exercising, and which one's going to be the most beneficial. But again, based off of what we know from geriatric or just normal populations, is that it takes a lot longer for that sympathetic activity to get back down. And so it's going to be a little bit harder. And one of the things we saw in the study that I didn't report on was something called your wake after sleep onset. So typically those that were more active later in the day, it took them a little bit longer to kind of wind down. So they were actually able to kind of wake up or they woke up more, and it took them longer to actually go to sleep, which was one of the other interesting things. So yeah, if based on my opinion, I would try to, if you are going to work out a little bit later, to make sure it's kind of a lower intensity and do the higher intensity stuff earlier in the day, if possible.
Thank you very much. I just wondered also, when you say cardiovascular exercise, would you consider or include in that cycling, treadmill, walking, even walking around a flat track? Is that,
Yes.
that would be okay? And then more resistance training and that sort of thing would not necessarily be cardiovascular for somebody with Parkinson's.
Right. Typically, cardiovascular exercises are, like you said,
Raise the heart rate.
that was the resistance training is going to be, free weights, machines, things like that. While
Right.
walking, whether it be on a treadmill, outside, cycling, all of those are going to affect the heart more. Obviously, the muscles are still being used, but that's considered more cardiovascular exercise.
Okay, thank you again.
You're welcome. Excellent question.
Do you mind
I'm
if
gonna give
I
you
pop it one more time?
Oh, yeah, that's fine.
Okay, since no one else is taking advantage of you, I want to know if a Parkinson's patient falls asleep very easily when it first goes to bed, but then wakes later. Have you done studies as to when the REM sleep is coming on in an individual with Parkinson's who goes to sleep very early and sleeps hard for a long time, and then starts this waking? Can you
Yeah.
differentiate between those different types of sleep for somebody like that?
Oh, yes. That's one of the things that the beautiful things about the sleep profiler that we like. It allows us to look at those different end stages, which are the non-REM sleep. And then it allows us to look at the actual REM sleep as well. So we can look at those. But one of the other things we look at that kind of contributes to that, again, are those autonomic activations, movement arousals as well. So rapid eye movement sleep, that deeper sleep, again, you may see more movements within that. And so what we actually saw, that people who had more movement arousal, so they moved or actively dreaming, woke up more, which kind of makes a little bit more sense. So these individuals were moving more, and so they kind of woke up a little bit in that case. And so that broke them out of that sleep. Now, were they able to get back to it as quickly? We have the data. I haven't gone back and looked at that data, but yeah, that's one of the things that we look at when we're doing the sleep profile, because again, everything's related. And so, it could be the disease severity, it could be the activity level. There's a lot of different factors that could contribute to waking and getting more of those arousals that would cause you to kind of wake up a little bit more often. We see this also, and like I said, in the Parkinson's community, is that these individuals have that lower sleep efficiency. So what that means is by the time they're sleeping, the quality of their sleep goes down. Even though in our particular study, we saw that patient-reported sleep times and when they actually went to bed were a lot longer in the Parkinson's group compared to the control group, but the sleep quality was much worse, or the sleep efficiency was much worse in that. And we did see a lot more of their wakings. So we saw that when they did wake, we saw increases in their wakings that lasted more than 30 seconds, as well as the wakings that lasted greater than 90 seconds. So we see those, when they do, we see a higher incidence of them waking up, but we also see them when they're awake a little bit longer as well. And so that contributes to the sleep quality within that. And so one of the things that we haven't looked at yet, and we'll plan on doing that, is the different types of activities. So the multimodal, the cardiovascular only, or the resistance training. Will those help reduce those directly after exercise training? And can we retain those effects over time as well?
Great, thank you.
Hi there.
Hi.
Hi. I'm really interested in the exercise approach to the treatment of Parkinson's. I'm also interested in, it seems to me the medical community is going down another route and putting an intensity of the research into new drug developments. How did it, in your mind, what is the optimal approach to the treatment of Parkinson's?
You know, that's a great question. And I've worked with a lot of neurologists, and a lot of them have various opinions on that. You know, the first thing is they probably put you on some sort of pharmacological intervention, levodopa, whatever, or an agonist that will basically, if you see improvements within that, then, you know, it helps them to identify and diagnose if you have Parkinson's. I'm a big believer in coming off a lot of those medications. Obviously, you need some of those medications to survive and to kind of move, but we also know that as the disease progresses, we can also get those levodopa-induced dyskinesias. At that point, you know, we're going to have to look at alternative therapies, you know, probably brain surgery, or, you know, with a deep brain stimulator or anything like that. So, you know, pharmacological intervention is a necessary evil in most cases, but the treatment of other aspects of the disease can be improved using non-pharmacological interventions. And that's one of the things that we're trying to prove here in doing that. If we see individuals, I tried to share my screen. If we see individuals that are able to, you know, decrease their blood pressure through exercise, well, they don't need to be on medication for that. If they're able to sleep better, you know, and they increase their quality of life through that, then they don't need to take medications for that. That improves their mood and reduces depression scores. They don't need to take a medication for that. So I'm a big believer in that. I mean, if you look at some of the assisted living homes and facilities and nursing homes, the average individual takes over 14 different medications. And that's just a lot to keep up with. And that's something that if we can get those individuals off through these inexpensive and free ways of intervention and treat these symptoms that can be treated in this way, it's a no-brainer for me. Now, obviously, you know, is this going to be a dopamine replacement? No. But can it facilitate greater changes in the physiological state? Yes. That's just my opinion.
Just a quick follow-up to that. To me, a basic question, why does exercise work? Does exercise work, I've been told, because it creates new neuron receptors in the brain that aid in the production of dopamine?
So
why does it work?
Yeah, one of the beautiful things about exercise is that obviously it has a huge physiological response. So if you start walking more, you're going to see improvements in your cardiovascular function. And that's one of the things we're looking at for this this future study. The big thing about this is getting the connection back. So with Parkinson's, usually we see reduction in goal-oriented movements. And so that's one of the things that we have to look at, is by understanding where the deficits lie. So walking is one of the first things that could be influenced, or, you start to see, dragging of your feet, missteps, things like that. That's something that you don't really have to think about. And that's something we call kind of this autonomous aspect. And Parkinson's affects those more than it does these kind of challenging, kind of learned movements. There was a YouTube video, a guy named Boss Bloom. I don't know if any of you are familiar with, he's a neuroscientist, I believe in Denmark, somewhere over there, the Netherlands. Brilliant man, very kind of egocentric in that sense, but a brilliant man. And what he saw is that individuals with Parkinson's were able to retain a lot of those learned movements. I had a patient come to me who could barely walk, came in on a cane, but when asked to do the waltz or the salsa, he got up and did it, no problem. So it's more about those connections that are there and restoring the ones that, quote unquote, I've heard some people say kind of the lazy motor patterns. Those you don't have to think about as much. So just standing still and, just normal walking. Those are the ones that are going to be really affected. And so what we've seen is that exercise can improve those aspects because you're putting more cognitive effort and attention to the actual task. As far as the actual, more neurons going to it and stuff like that, that's a little debatable. There's been a lot of conflicting evidence of that. But by doing these practice movements and learn movements, that's really what helps kind of carry over to the improvements in the motor functions that we see. Now, with that, we can see all the other effects that, exercise increases oxygen and hemoglobin to different areas of the brain. I've done a couple of papers on that. And if you do that, you can improve cognition, improve those scores, reaction times, working memory. So that's obviously a really, really good thing. But again, we see a lot of those improvements all over the place.
This is the final one. How do we stay in touch with the results of your research?
I am happy to give you my email. I'll put it up in the chat. Everyone can look at that and contact me.
Exercising too.
It is, I've just put it into the chat. So if you want to copy that down and look at it, and then contact me anytime you have a question, or if you do feel like coming up to the clinic, if you're available, I would be happy to see everyone.
Could you put the website up again, please?
Yeah.
Skinner.
My email?
Yes, please.
Okay. You see it in the chat?
No, I don't see it yet. Just
Okay. Yeah, I can put that up here again.
Oh, okay.
And then you can also, for those of you that are interested,
App stated. Okay. Thank you.
and for those of you who are interested in coming to the clinic, this email is for the interprofessional health, health and human services. So we would, if you want to come up and get scheduled for whatever, this would be the email to contact, and they will put you on the schedule, kind of tell you what's involved and everything, or you can do that through me. And I'd be happy to share that. This fall, we're going to be doing some more projects. And if you just want to stay in contact or be involved in some of maybe the long distance research we do have going on, I'd be happy to keep you in our file and reach out to you when we have studies that meet those qualifications. And if you just want to know more about that, we're getting a website up right now, hopefully in the next month. and you can follow along with what we're doing here for the Parkinson's community. Thank you very much.
Thank you.
Thank you.
Thank you. I appreciate it. Thank you all for letting me come on today. And again,
Um,
if you have any other questions, I'm happy to talk, or if you just want to shoot me an email later on, I'm happy to respond to those as well.
I guess that's it.
Right, just so everybody knows, I will be doing a follow-up email. This is recorded. So if you missed anything or you want to rewatch it just to get some more information, I'll be sharing that with everybody who is joining us today. I'll be sure to include his email and the email for the Health and Human Services email in that follow-up email. So I'll just send everything to you all at once so you don't have to copy it or write it down immediately. I'll be doing a follow-up email later today with all of that information. And I'm gonna give you guys just a few more minutes. If you have any more questions, feel free to ask away. While you're entering all of that information into the group chat or trying to unmute yourself, I'm gonna go through some upcoming events. Let me turn my camera on. I just forgot that it's not on. So our upcoming events, we do have two things going on next week. We will be having a virtual cooking class that is limited capacity. So if you want to register, you can call our office. The phone number is 980-245-2786, or you can email us directly and we can get you registered for that. It is next Wednesday at 2 p.m. And we will be doing two more of those virtual cooking classes. Call to register in advance. I believe the next one is August, the second week in August, and September 22nd. So both of those are open for registration. And then we will also be doing a educational webinar next Thursday at 6 p.m. It is titled The Introduction to Parkinson's Disease. It's going to go through the entire disease progression, treatment, everything that you could possibly need and information on Parkinson's, including medical and treatment options for the future. So all of that information is up on our website at www.parkinsonassociation.org. I'll include all of that information in the follow-up email for this virtual support group as well. And I believe I said at the very beginning, we will continue virtual support groups on the first Wednesday of every month at 2 p.m. We already have two of our speakers lined up for August and September. I don't remember what month we're in. So all of that information will be up on our website as well. If you're registered for this virtual support group, you are more than likely going to be registered for those support groups as well. But I will do a follow-up email before those events happen so you can get the information for that as well. I'm going to give you just a few more minutes to ask questions. So take it away.
Quincy, I was looking on the website for the introduction to Parkinson's disease, and all I see is one from June 10th that's already done.
Let me see if it's updated. I know we updated that, I believe, this morning. So let me make sure that the link is updated and it's not just the date that's wrong. Yes, okay, so it should be updated now. If you don't have it, I can put the registration link in the chat box now.
I see it now. Thank you.
Awesome. And just in case anybody else wants to register and doesn't want to take a trip to the website right now, I did just put the registration link for that webinar next Thursday at 6 p.m. in the chat. All right, if if we don't have any more questions, thank you, Jared, for coming on today and speaking to us. Thank you, everybody, for joining. And I'll see you guys next month. Have a great rest of your afternoon.
Awesome. Thank you, everyone. Really appreciate it.